Good morning. Welcome to the Endocrine Society's first news conference of ENDO 2021 on diabetes. My name is Jenny Glenn Gingery. I'm the Associate Director of Communications and Media Relations here at the Society. Before we get started, I'd just like to go over a few items about the structure of today's event. We're going to have three presenters discussing various aspects of diabetes research, and then we'll be having the Q&A period at the end. So feel free to, at any time, type any questions you have into the Ask a Question box at the right of your screen. And once you submitted those, we will go ahead and answer them at the end of today's presentation. Please be sure to include your affiliation. This press conference is being recorded, and it will be available here on endowebcasting.com, as well as the Society's YouTube channel and our website following the presentation. We're very pleased to have with us Dr. Neil Lawrence of Sheffield Children's Hospital NHS Foundation Trust in Sheffield in the United Kingdom, Dr. Hafiz Shaka of John H. Stroger Jr. Hospital of Cook County in Chicago, and Dr. Manish Raisangani of the University of Arkansas for Medical Sciences and Arkansas Children's in Little Rock, Arkansas. Over the next 30 minutes or so, each speaker will present their findings, and we'll be ending again with the Q&A session. I'd now like to invite our first presenter, Dr. Lawrence, to speak.
Thanks, Jenny. Hi, I'm Neil, and I'm just here to talk about some work that we did whilst I was working at Doncaster and Bassetlaw Teaching Hospitals, which is a large teaching hospitals in the north of the UK. And we were looking at the diabetic glycemic control before and after the first national lockdown in the UK back last year. We've got nothing to disclose, and I thank you very much for your attention. So Jenny, if you want to hop onto the next slide. What we did is we took 2 3-month periods, one from December 2019 to March 2020, just before the national lockdown, and compared that to 3 months following, from the 30th of March 2022 through to the 21st of June 2020. And we looked at all of the patients, all of the children and young people under 19 who had either continuous glucose monitors with the Dexcom system, or flash glucose monitors with LibraView, or were just monitoring their blood sugars regularly with intermittent measures. And we looked at all of the data that gets uploaded automatically onto our online systems. And we had a total of 80 patients to look through with a median age of 13.6 years. So Jenny, if you want to go to the next slide. And we saw some significant differences before and after lockdown. The average blood sugar did decrease from 9.7 to 9.5 millimoles per litre in those with continuous monitors on. And the variability of their blood sugars decreased as well. So the average standard deviation of their blood sugar went down from 4.4 to 4.1 after the lockdown. If you want to go forward, Jen, thanks. We also had a look at the HbA1c. We had more patients to look at for this because this included the whole cohort. So we actually had 120 patients who had an HbA1c reading before and after lockdown, and that decreased significantly from 67.4 to 61.3 millimoles per mole. And what we did for that, and it's important to mention, is obviously these are children, and so you've got to consider the honeymoon period after diagnosis, but we did exclude all children that had been diagnosed in the 12 months prior to the beginning of the first period we looked at. So that is not including any honeymoon effects that we're seeing there. We're just seeing a significant lowering of the HbA1c. And you worry that in that sort of situation that it might be being skewed by an increased time hypoglycemic. But what we did, we looked at the percentage time in range in those that did have continuous glucose monitors on again. And we saw that the time below range in hypoglycemia didn't actually change. But what we did see was a significant increase in the time spent in range from 55% all the way through to 58% following lockdown. So this change in HbA1c was driven by higher time in range. Next slide, please, Jim. Like everywhere in the world and everywhere throughout the UK, we had to make service adaptations throughout this period. When the lockdown was announced, NHS England put out an email asking us to cancel all face-to-face consultant appointments unless there were special circumstances. And this gradually got opened back up in June, July time in 2020. And this was a statistically significant difference. This was if you do a chi-squared on these numbers, there was a significant difference in how we were interacting with the patients. So face-to-face consultations decreased from 245 in the period before to 151 afterwards. But in replacement for this, we increased contacts via either video or phone consultations, going up from 1,700 to 2,200 between the periods. And at the time, people were worried that these sorts of changes to the service would have detrimental effect on the glycemic control. But as we've seen from the data that we've shown today, this wasn't the case. Control got better, and there was no evidence that any of those service changes were detrimental. We also put in a few other things alongside that. So we had a drive-through clinic where patients could either get their HbA1c measured using the point of care analysis that we normally use in clinic, and also we offered an opportunity for people to upload data from their monitors in that drive-through service in case they didn't have appropriate equipment to do so at home because of the lockdown. So overall, there were significant changes to the service, but there certainly wasn't any detriment in the glycemic control. Next slide, please, Jim. So in summary, the UK national lockdown led to improved blood sugar control, as shown by the data from our unit. It really shows how difficult it is to manage type 1 diabetes outside of the home. This is a behavioural disease, and the increased time at home and perhaps the increased pressure and awareness of health during that first lockdown, when everyone was anxious and aware of their health, perhaps more than normal, really came through in improved control. And we've shown that increasing the number of remote consultations is not necessarily detrimental to control, and it should really impact upon service provision changes in the future, where we should think more about how best to connect with patients in ways that are most convenient for them. So that's my last slide, folks. I'd be very happy to take any questions on that work.
Thank you so much, Dr. Lawrence. Now we're going to go ahead and invite Dr. Shaka to speak.
Hi, my name is Dr. Shaka. I'm from John H. Schroeder Hospital of Cook County at Chicago, the United States. And I'll just be giving a talk on my presentation, which is titled The Rates and Predictors of 30-Day Readmissions in Adults with Type 1 Diabetes who were hospitalized for diabetic ketoacidosis. And this is a nationwide study. It's based on the National Readmission Database for the United States for 2017. These were my co-authors, co-investigators, and we are all affiliated with the hospital. Next slide, please. For disclosures and conflict of interest, all authors have no conflict of interest, and we did not receive any funding during the course of this research. Next slide, please. So as way of introduction, diabetic ketoacidosis is one of the emergencies in endocrinology, and it's actually something that has been known to be associated with increased morbidity and mortality. Diabetes is a chronic condition, but diabetic ketoacidosis is one of those reasons where a patient who is diabetic gets admitted. It is a state that is more common among patients with type 1 diabetes, just because you need insulin to kind of maintain the fat and the lipid levels in the body. so that these patients that have an absence or near absence of insulin, once they don't get their requisite treatment or their insulin shots, then they start breaking down the fat and lipid into ketones, which develop acids in the body, leading to acidosis. Now, there's a distinct difference between the types of diabetes in patients type 1 versus type 2, where the type 2 has only a relative deficiency of insulin or more of insulin resistance. So in this patient, in type 2 patients, they actually have insulin, so they are not as prone to developing acidosis when they have high blood glucose. So this study was basically done to assess the rates of readmissions. This is patients who initially had an episode of diabetic ketoacidosis and got discharged from the inpatient setting, then get back to the hospital within the next 30 days. Next slide, please. So the methods we use is we queried the 2017 database of the National Readmissions Database. This is an adult database of United States hospitalization between January 1st and November 30th, 2017. We excluded December just because for you to get the correct cohort of patients who were readmitted, the December time period would exclude data for the adjacent month there. So, and we also excluded patients who were electively admitted or admitted for other traumatic reasons so that we could get patients who were readmitted within 30 days for something medically related. And then we assessed the 30-day readmission rate. This is this is actually a marker many hospitals and many health systems use to evaluate inpatient stay as well as hospital metrics in terms of standard of care. We assess the mortality during the rehospitalization, how long the patient stayed in the hospital, and how much it costs patients to stay. Then we develop a regression model to identify factors that might predict the rate, the readmissions in patients with diabetic ketoacidosis. Next slide, please. So for the results, we had over 91,000 hospitalizations during the study period who were principally, meaning diabetic ketoacidosis was the main reason for their hospitalization. And of these patients, we discovered that just over 1/5 of them were readmitted within 30 days. This accounted for over 18,000 patients. So a majority of patients who were readmitted were again readmitted due to diabetic ketoacidosis as well as other hyperglycemic emergencies. And we also found out that these patients, after the 30-day readmission, compared to the index admission, they had over twice the mortality rate. Readmission was also associated with a longer hospital course compared to the index admission, and then the significantly higher cost of hospitalizations were noted. Next slide, please. So in terms of the independent predictors of mortality, of readmissions, we found out that females were at least 14% times more likely to get readmitted, even when you adjust for all other factors, including the age, the comorbid burden, and hospital characteristics. Other predictors of readmission included patients who were discharged against medical advice. This patient had over 50% more chance of getting readmitted within the 30-day period following the index admission. Other predictors included patients who had hypertension, chronic kidney disease, and anemia during their index admission. we noted that obesity and hyperlipidemia were associated with a lower rate of readmissions following an episode of diabetic ketoacidosis. Next slide, please. So in conclusion, about a fifth of patients who had an episode of diabetic ketoacidosis in patients with type 1 diabetes get readmitted back to the hospital within 30 days of discharge. This is a significantly high number, and we found out that the second admission, which is the readmission, was associated with higher inpatient mortality. Now, hypertension, chronic kidney disease, being discharged against medical advice were independent predictors in patients with diabetic ketoacidosis. However, obesity and hyperlipidemia were associated with lower rates from our studies. We discovered also that there was significantly increased utilization of healthcare resources during the following or subsequent readmission compared to index readmissions. And we kind of recommend that these factors should be identified quite early during the index admission as a way of significantly preventing readmission, which is something most hospitals tend to work on, and something that would also help reduce the burden of morbidity and mortality in patients with type 1 diabetes. Thank you. I think that's all.
Thank you, Dr. Shaka. I'd now like to invite Dr. Raisingani to present.
Good morning, everyone. Thank you for this opportunity to speak today. So my name is Manish Raisingani. I'm an assistant professor at Arkansas Children's Hospital, University of Arkansas for Medical Sciences. And today I'm going to talk about risk of complications in children with type 1 diabetes and COVID-19. So I have no financial relationships to disclose. So let's talk a little bit about the COVID-19 pandemic and type 1 diabetes. The COVID-19 pandemic started in late 2019, as we all know. There is some data available in adults which shows that both type 1 and type 2 diabetes can be associated with increased risk of complications with COVID-19. There is a study from England by Barron et al., which showed that both type 1 and type 2 diabetes were independently associated with a higher risk of in-hospital death in adults with COVID-19. There is very limited data available for pediatric type 1 diabetes and COVID-19 infections. So we looked at this database. It's called the TriNetX database. It's a large international database for COVID-19 patients. It collects real-time information from their electronic health records. It covers over 60 healthcare organizations from over 31 countries. So we looked at children who were between the ages of 0 and 18 and diagnosed with COVID-19 infection with and without type 1 diabetes, looking for complications of mortality, sepsis, and intubation. So first, let's look at the mortality data. So if you look in the second column, these are patients who had COVID-19 infection, but no type 1 diabetes. Column 3 includes all patients with type 1 diabetes and COVID-19 infection. And the last column includes kids who are very well controlled, which is basically defined by a hemoglobin A1C under 7%, who also were diagnosed with COVID-19 infection. So first, looking at column 2, which has kids who had no type 1 diabetes with COVID-19 infection. As you can see, we had over 500,000 patients in this group. And if you keep looking at the database, it keeps updating. And this morning, there were closer to 600,000 patients. So it keeps updating. So it's a great source to keep tracking. So there were about 235 deaths and a relatively low percent of 0.04% mortality rate in children without type 1 diabetes and COVID-19 infection. Now, if you go to column 3, these are children with type 1 diabetes. We had about 3,000 kids in this group. There were about 10 deaths with a much higher percent of 0.328 mortality rate. And then looking at the relative risk in red, there was a 7-time higher risk of dying from COVID-19 if you had type 1 diabetes. Now, I haven't shown that data here, but if you use a A1C cutoff of over 9, so the very poorly controlled kids with type 1 diabetes, this relative risk actually increases to about 15. So higher the A1C, the higher the risk of dying with COVID-19 infection. Now, looking at the last column, these are the well-controlled kids with type 1 diabetes and COVID-19 infections. Here in this group, you see there was 0 deaths in the 482 patients that we had. Again, this basically shows that if your type 1 diabetes is very well controlled with a very good A1C, the risk of dying from COVID-19 is not much different from the general population, which is very reassuring to some parents. Now, this is data looking at sepsis. So similar slide, similar columns. Column 2, again, children without type 1 diabetes. If you see, there were 575 kids with sepsis, with quite a low percent of 0.11 who had sepsis with COVID-19 infection. Moving on to column 3, the kids with type 1 diabetes. Here again, you can see the percent risk was higher at 0.49%, and a relative risk was about 4.3 with a p-value which was quite significant. Moving on again to the last column. Again, if you see the kids who are very well controlled, 482 kids, none of them had sepsis. And again, going to show that if you have well-controlled diabetes, you will have, your outcome would not be much different from kids who don't have type 1 diabetes. Next slide, please. Now, this is looking at intubation rates. Of the 500,000 kids who did not have type 1 diabetes, 142 required an endotracheal intubation with a percent risk of 0.02, while in kids with type 1 diabetes, this risk went up to 0.3% and a relative risk of 11. And this was much higher if your A1C was over 9. And then the last column again shows very, very similar data where you see that none of the kids who were well controlled with an A1C under 7 had to be intubated with COVID-19 infection. Next slide, please. So in conclusion, I would like to say that type 1 diabetes with COVID-19 infections puts children at higher risk of complications, and higher the A1C, the higher the risk of complications. We did see that if your A1C is under 7, you have excellent outcomes with COVID-19 infections, and most of these kids will have a very, very mild disease. Hence, it is all the more important that during these times that children keep their blood sugars under well control to prevent hospitalizations, death, and other complications with type 1 diabetes. Next slide, please. So these are my references. This project was supported by the Translational Research Institute grant from the NIH at Arkansas Children's Hospital. I also reviewed the TriNetX database. And thank you for your time, and I'm happy to take any questions at the end.
Thank you so much, Dr. Raisangani. We're now ready to go ahead and take questions. Again, if you can type your questions at the right in the Ask a Question panel, we'll go ahead and pose those to the speakers today.
Great. I'm Colleen Williams. I'm the Manager of Public Relations, just jumping in here to help with the Q&A section. We've actually already gotten a couple of questions here in the chat box, so I can go ahead and get us started. The first one is for Dr. Lawrence. And this question is from Rhea Tang at Close Concerns. And the question is, were similar trends seen between children on CGM versus using intermittent testing? How widely is CGM used in the UK in pediatric populations?
Hi, thanks. Yeah, there was a difference in the populations that we saw in the age, and it's a lot to do with funding. So children who have particular difficulties with their blood sugar control, or they've got genetic differences that are likely to cause more challenging glycemic control, tend to find it easier to get funding to get the continuous glucose monitors, the sort of monitors that have the Bluetooth enabled capability. And they're also more likely to get funding for insulin pumps in parallel to that. So in our population, the CGM children were younger than those either using the flash glucose scanners or the intermittent monitors. And we did see in the continuous glucose monitors that they had the strongest effect, the largest difference in pre and post lockdown blood sugars and improvement in the variability and the time in range. And I think that's partly statistical in the sense that they often have a baseline blood sugar control that's slightly worse than the other groups, and so they've got further to improve, if you like. But it's an interesting point, because there's been some other research that's come out of Italy that's actually not seen as much of an improvement in teenagers, and they saw a significant improvement in younger children, and they also saw an improvement in adults, but that they didn't find that improvement in their teenagers. And that doesn't quite agree with our data. We definitely saw improvement in teenagers, because a lot of our teenagers are using the LibreView flash glucose scanning system, and there was still a significant improvement there. But I think it's important to bear in mind those differences and appreciate that there's going to be different challenges between dealing with children before puberty and dealing with teenagers going into adulthood, and you should bear that in mind when you're managing people in clinic.
Great, thank you so much for that thoughtful response. We have another question here. This one is for Dr. Shaka, and this is from Mike Manostra from Endocrine Today. And the question is, was it surprising to see obesity and hyperlipidemia being associated with lower rate of admission for DKA?
Oh, okay, thank you. That's a very good question. So I do a lot of obesity-based research, and if you're familiar with certain concepts that have come up recently, one will be like the obesity paradox that has been reported in a couple of hospitalized patients for various conditions, including strokes, heart failure. And the other concept is what they term as metabolically healthy obesity. However, in this population of type 1 diabetes, I think the reason why obesity seems to be protective in this case is because obesity might be a surrogate marker for patients who had been traditionally more compliant with insulin. Because as we know, in patients with type 1 diabetes, they need insulin to kind of store body fat. Now, most of these patients patients who are poorly controlled tend to be either underweight or within the normal limits. Patients who have been more compliant with their insulin, they are the patients who tend to be more overweight and have probably lipid disorders. So that's a possible hypothesis, and it remains to really be tested as to see if there's a pathophysiologic or another pathophysiologic basis for it.
Great, thank you. We have our next question from Medscape reporter Miriam Tucker. It's a little bit similar, also for you, Dr. Shaka. Is the 20% readmission rate surprising? And is it similar to previously reported rates? Also, how do you explain the apparent protection from obesity?
I think I already explained the part from obesity. So I'll just go for the readmission rate. Now, 20% readmission rate, it was quite surprising, and it's quite high by any metrics. That's one in every 5 patients. And this is just looking at the window of 30 days. Now, it means if you extend it beyond that, you are averaging almost 1 to 2 readmissions for patients per year, which it's not something that talks so much well about the patient's glucose control. Now, this patient population might be peculiar because you have other medical conditions, including a study that was done on all diabetic ketoacidosis cohort that reported a readmission rate of about, I think, 12 to 13%. And when you compare it with readmissions for other chronic conditions such as heart failure, this amount is quite alarming, if I would say so. And as I said, I already think with the first question, I kind of gave a slight explanation of why we thought obesity might have helped patients to avoid readmissions. It's just been like a marker for patients who were traditionally more likely to get insulin. And since we know lack of insulin has been one of the most implicated precipitants of diabetic ketoacidosis, especially in patients with type 1 diabetes, then that might be a factor.
Okay, great. This is another question for you, Dr. Shaka, from Close Concerns again. What was the average total hospitalization cost for admission and readmission in type 1 versus type 2 diabetes patients?
Okay, in our current study, we did not compare type 2 diabetic patients with the cost of hospitalization for the type 1. And this was on purpose because the patients, the age group differences between patients who are traditionally type 1 versus the type 2 diabetic patients is so large, so that in between you have a way higher comorbid burden on patients with type 2, which would significantly contribute to their inpatient length of stays and inpatient cost of hospitalization. So a direct head-to-head comparison between type 1 and type 2 diabetes was not done in this study. We only compared how much it cost the hospitals during the index hospitalization compared to what it cost with the readmission. We found out that the readmissions were quite higher in cost, and the goal is to actually prevent all costs associated with readmissions, or a significant proportion of it. One of the things that was not highlighted here was the total cost of readmissions to the United States population within that year, and the patient, which ran into millions of dollars. So if we can cut down on just a fraction of that in terms of readmission, will not only save patients from being hospitalized, which counted for thousands of days lost in terms of productivity, but also decrease the cost on the healthcare system.
This question is from Kristen Monaco for Dr. Shaka from MidPage Today. Do you have any data on whether these patients were on multiple daily injections or insulin pumps?
Yeah, so that's a good question. So this database is purely inpatient, and the Endocrine Society has its own different best practices as how to monitor blood sugars within inpatient setting. Now, we assume most hospitals have their own protocol, but these are usually adapted to meet the national guidelines. But in the inpatient setting, you have well-controlled or well-monitored blood glucose reading, depending on where the patient is admitted. Majority of patients who have DKA tend to be admitted in the intensive care unit, where they receive way closer monitoring too. However, from the nature of the database, it couldn't be determined if these patients were still on continuous glucose monitoring while in the hospital versus just intermittent, or we couldn't also account for how frequently their blood sugars were being tested. Again, because the treatment protocol for diabetic ketoacidosis tend to vary with individual treating center.
Great. And then we have a follow-up question here from Medscape. Why might females be more likely to be readmitted?
That's a good question. There's always a belief that females, and we have some research backing this, that females tend to be more health seeking for disease severity than the average male. I have not seen a particular study done on type 1 diabetes to see if this also applies to this cohort, but that could be one of the reasons. It could be that the females tend to present more when they feel they're going into DKA compared to males. And even after adjusting for age and disease comorbidities as well as hospital factors, this remained a strongly positive predictive feature. And this is also consistent with other studies that have been done on DKA population. It brought up an interesting research topic, which would be to assess if there was a difference in outcome between males and females during hospitalizations for the DKA. And that's something my research team will be working on soon.
Great, thank you so much. We really appreciate you answering all those questions on your study. I just wanted to quickly ask Dr. Razangani a question and switch over to the COVID pediatric study that you did. So what advice would you give to parents of children with type 1 diabetes about returning to school? We know that's a big question right now. I think you're on mute.
Yes, thank you for the question. I know it's a big question that we get asked in clinic all the time. And as you looked at the data, the higher the A1C, the higher the risk of having complications with COVID-19. And if your A1C is usually under 7, then you will not have significant complications with COVID-19. So I would say that, if you have well-controlled type 1 diabetes, then it should be safe to go back to school, obviously taking all precautions like masking, social distancing, etc. On the other hand, if your A1C is over 9, where the risk of complications increases significantly, I think these kids would best it would be best for these kids to attend virtual school until they can get their sugars under better control. Thank you.
Great, thank you so much for that response. So Jenny, I think that's all the questions that we had come through from reporters for now. So I'll kick it back over to you unless we get any last minute questions here.
Great. Well, I just wanted to say thank you again to our amazing panel of speakers and all the journalists who took time to join us today for this fascinating discussion. As a reminder, these news conferences will be available here at endowebcasting.com as well as on our website and YouTube channel in the coming days. If you have any additional questions or you would like to set up any interviews with our experts, feel free to contact Colleen and myself at media@endocrine.org, and we'll be happy to help. Thank you again. We'll be reconvening here at 1 p.m. today for our COVID-19 and endocrinology news conference, and we hope to see you there. Thank you so much.